Good afternoon, everyone. I'm Janice Whitaker, CGNE Administrator and Community Liaison, and it's my pleasure to serve as host of the CGNE Seminar Series. This program is being provided by the Tressa Neese and Helen Diskovich Center of Geriatric Nursing Excellence at the Penn State Ross and Carol Neese College of Nursing, in collaboration with the Office of Outreach and Professional Development, the Center for Nursing Research, and Age-Friendly Care PA. Today's seminar is entitled Fall Preparedness and Home Safety for the Older Adult, and it will be co-presented by Dr. Mitchell Straub, physical therapist and owner of Vital Rehab and Wellness, as well as Jenny Rank, occupational therapist and CGNE education program specialist. Before this informative seminar begins, there are some disclosures and announcements. Penn State Ross and Carol Neese College of Nursing is approved with distinction as a provider of nursing continual professional development by the Pennsylvania State Nurses Association, an accredited approver by the American Nurses Credentialing Center's Commission on Accreditation. Mitchell Straub, content expert for this educational event, is the owner of Vital Rehab and Wellness. All financial relationships listed for this individual have been mitigated. Participants with a valid RN license who attend the entire Nursing Continual Professional Development Program can earn 1 contact hour. Partial contact hours are not awarded. In order to earn contact hours, Zoom in and out time will be recorded, and the post-event evaluation survey must be completed. As a reminder, this seminar is being recorded, and if you have any questions, please, they will be addressed during the QA and discussion portion of the seminar. Please put them into the chat feature, or you can raise your hand and we will unmute you and you can share your comments or questions aloud. The post-event evaluation link will be placed into the chat, and it will also be emailed to you within 24 hours. This evaluation must be completed within 1 week of the seminar. While it's required for RNs seeking contact hours, we do ask that all participants complete the evaluation. This helps us with our data collection about the seminars, as well as our activities related to age-friendly care. Nursing Continual Professional Development certificates will be emailed to RNs meeting all the requirements within 1 month of the seminar. And if you have any questions or concerns, you're always welcome to email us at cgne@psu.edu. Next, I'd like to introduce Olivia Rubio, who has recently been accepted as a CGNE graduate student affiliate. Olivia is concurrently enrolled in the PhD and Adult Gerontology Primary Care MSN programs. She's also part of the Age-Friendly Care PA team. We are thrilled that Olivia is a valuable member of our center and college. And thank you so much for being with us here today, Olivia, to introduce our speakers.
Thank you, Janice. Dr. Mitchell Straub has been a practicing physical therapist for over 7 years here in the Center County region. He completed both his undergraduate and graduate studies at St. Francis University, and after graduation has spent the large majority of his career working with older adults. After 3 years of practice, he sat and passed the board examination for geriatric clinical specialist through the ABPTS. He launched his own company in April of 2021 that specializes in helping older adults age successfully in the home by regaining and maintaining their independence. Jenny Rank is a graduate of Elizabethtown College and has been practicing as an occupational therapist since 2014. Her passion is working with older adults with clinical experience spanning across memory care, long-term care, subacute rehab, and assisted living. She has worked with diverse populations all the way from Oregon and Hawaii to Pennsylvania. She is registered through the National Board Certification of Occupational Therapists and is a certified dementia practitioner. She is currently the Education Program Specialist at the Tressa Nice and Helen Diskovich Center of Geriatric Nursing Excellence.
Very good. Thank you for that wonderful introduction, Olivia. I am going to go ahead and get my screen pulled up to share here. All right, as Olivia had said, my name is Dr. Mitchell Straub. I am a physical therapist and board certified geriatric clinical specialist and owner of Vital Rehab and Wellness, where we specialize in working with older adults. So older adults is really my passion and what I have really found myself enjoying the most in my career, and an area that I've worked in a ton and focus on a lot in my work is balance, fall preparedness, and fall prevention. The very first thing I think it's worth pointing out, the title of the presentation, Fall Preparedness and Home Safety for the Older Adult. I think most commonly we're used to seeing the word fall prevention. And though fall prevention is very important, I think one area that we miss a lot as clinicians and healthcare providers as a whole is this area of fall preparedness. So we're going to dive into that today. We'll also talk about fall prevention as well, because that's an important piece. But it's also very important to highlight fall preparedness because we're never going to reach a point where we totally eliminate falls. So we need to make sure that we prepare our clients, our loved ones, in the case that a fall does happen. What can they do to get back from that situation? So first, let's talk about the statistics. It's super important to understand why we're talking about falls and how important falls are. So falls ranked as the 18th leading cause of disability-adjusted life years across all ages, outranking other diseases like dementia and chronic kidney disease. For older adults over the age of 70, it's the leading cause of injury-related death, which for me, that number stood out tremendously. My mind would go to motor vehicle accidents. So falls are more tragic and can lead to more deaths than motor vehicle accidents for adults over the age of 70. And it's estimated that 1 in every 3 persons over the age of 65 years old will fall each year. So 1 out of every 3 older adults that you know is likely to fall within the next year. So it's something that definitely needs to be talked about, and a lot of leading researchers, especially prior to COVID, were calling falls an epidemic among our older adults because it's becoming that big of an issue. Fear of falling and fall preparedness almost go hand in hand. And we're going to talk a little bit more about why that is. First, I want to give you an example of how fear can impact performance. And this is something that I talk about with almost all my clients, and I give them this example. So when I'm with a client, and we normally see clients in their homes, I'll actually stand up on like a step stool or a small height edge with my heels hanging off over the edge, and I'll have a conversation with them. And normally I'm able to have a normal conversation. I'm able to stand comfortably and confidently without issue. And then I tell them, take me how I am now in this conversation and transport me to the Empire State Building. And imagine if I'm still able to have the same conversation. Am I still able to stand confidently and comfortably in front of you? Probably not. I am more than likely not going to be speaking. I am sure that I will be trembling in fear. And because of that fear, I might even fall. And you need to think, well, what's changed? What changed for me standing in someone's living room to being on the Empire State Building? The big thing is the height, obviously, and the fear of what could happen. Because I know if I fall, from a step stool in someone's home, I'm just going to step down to the ground and there won't be an issue. But if I fall from the Empire State Building, obviously there's going to be a lot worse consequences. So that's a very, very big example as to how fear, just fear alone, can impact performance. I'll give you one more example, and this is a more real example of a client that I worked with in the past. She had told me that she never goes in through her front door. And I asked her why that was. And she told me that at one point she suffered a fall stepping up onto her porch and will never use that entrance again, which I felt was an issue, that she was restricted to only going into parts of her house due to fear. So we got out to that front porch and we practiced trying to get up. So she took one step up onto the porch. As soon as her 1 foot got up there, she was frozen, stuck, couldn't move, and was trembling in fear, almost convulsing. She was so nervous. And if I wasn't there, she undoubtedly would have fallen. And again, she had the ability to complete the step. She had the strength, the balance. She had all the tools needed to do it. And we practiced it in kind of some other settings. And I know she could do it. But the fear for her was so limiting that she was unable to complete the step up. So false preparedness can be such a big tool because it can help combat that fear of falling. So here's some questions that I have listed on here that are good reflective questions for older adults, or good questions for clinicians to ask older adults. Is simply, have you fallen before? If they have fallen before, they might be afraid to fall again. Or asking them, are you afraid to fall again? Have they started slowing down? Either asking them that, or you might even notice that they're starting to slow down. Fear of falling is one of the leading causes of falls actually happening. And those simple questions can give you a big clue as to what their fall risk might be. So I'll ask rhetorically, why do you guys think people are afraid of falling? There's 2 big factors as to why people are afraid of falling. I just want you to think about that for a second. What are the 2 factors, 2 biggest pieces that people might be afraid of falling? The answer is they're afraid of one of 2 things. They're afraid of either getting hurt, or they're afraid that they won't be able to get back up after they fall. So what do we do for falls preparedness? Is we practice those 2 very things. The idea of falls preparedness is to increase someone's confidence so that they know that they can do and take the right steps to not injure themselves and be able to get up off the floor if they do fall. So in order to teach someone how to fall properly without injuring themselves, and yes, that's something that we will actually do. We'll teach and work with clients to show them how to fall properly. And it's 2 biggest areas where we see injuries that can be prevented with training. It's head injuries and upper extremity injuries. Sometimes, like you think of pelvic fractures, rib fractures, those are a little bit more difficult to actually prevent or to teach strategies on how to prevent. But head injuries and upper extremity injuries are something that can definitely be taught and learned how to prevent. So what we'll do is we'll set out a mat. Clients will sit down on that mat, and they will be sitting, legs out in front, and they'll just practice falling backwards. Okay. And what we'll do is we'll teach 2 things. We'll teach them to chin tuck as they start to fall to the ground. The reason for the chin tuck is so that they don't get that head snap back where they could risk hitting their head off the floor. So if they tuck that chin and fall more on their buttocks and lower back, it'll protect them from their head snapping back and hitting the floor. The other idea that we teach is this idea of disperse the force. So we teach them that as they fall back, they put their arms out. They don't put their arms back. They don't reach for the ground. They reach out. And the idea, again, is to help disperse the force so it's not all going through their pelvic area or their low back as they hit the ground. It's also being dispersed through their shoulders and upper arms so that there's less force on any one part of the body. So we'll start on a very low surface, sitting on the mat, and then just progress that as they start to learn the activity. We'll move from a seated position to like a very, very low squat, and we'll slowly start to up the squat. Now, we obviously never get to a place where they're in a full standing position and they get a fully accelerated fall to the ground. That wouldn't be safe to practice, but we're at least giving them some muscle memory techniques to learn how to fall appropriately. So that's step number one. Step number two is teaching them, okay, now you're on the ground, you're okay, you didn't hurt anything. How do you get up? How do you get from down to the ground and then back up onto your feet? And we'll teach that a lot as well, using assistive devices. I know Jenny actually has one picture on her presentation of a device that can be used to help get off the ground, which I loved. We could also use couches or chairs or lower beds to help get up off the ground, and teaching different strategies on how to do that safely. So that's the falls preparedness side. Now, it's obviously important. We want to hit both. We want to talk about falls preparedness, but there's also areas to talk about falls prevention as well. But we know we're not going to prevent all falls. But if we can prevent as many as possible, that's always a good thing. So there's 4 systems that we rely on for balance. And there are visual system, vestibular system, musculoskeletal system, and our somatosensory system. So we're going to talk about each of these. We're going to talk about how each system impacts our balance and how each system gets impacted with age, because all of these systems deteriorate one way or another due to the aging process. So first, the visual system. We rely heavily on our visual system to maintain our balance. I want you guys all to think about, go back to your childhood, and at the playground, that, I don't even know what you call it, but that the play set that spins in a circle and you can run around and spin it real fast. Think about sitting on that and then trying to jump off. And if you ever were trying to walk after you got off of that, it was very difficult. What our visual system does is it fixates on objects when we're walking or standing. That helps orient our brain to midline. So when that gets impacted in different ways, our balance can be impacted. We know that as we age, our vision decreases. This is a well-known fact. Think about even people that you know who have gone through the aging process. They may need corrective lenses when they didn't need those lenses in their 20s or 30s. They may require readers now at this point. So we know that the visual system decreases as we age. There's some situations that are worth pointing out where our vision is decreased within the home that puts an individual at a greater risk for falls. Some of those areas are bathroom trips in the middle of the night, where we don't have a lot of well-lit areas. We might not be able to pick up an object to fixate on, and that could definitely lead, and we see a lot of falls happen at that time. Same kind of example, trying to walk around without proper corrective lenses. A lot of people who wear glasses, they obviously take them off when they go to bed. They might not put them back on when they first try to go to the bathroom, and that blurred vision could leave them susceptible to a fall as well. And also standing in the shower and closing their eyes when washing their hair. So once we close our eyes, we lose that visual system completely. So we're actually cutting out an entire system that we rely on. And we see a lot of falls happen in the shower when they're going through that process. So that's the visual system. Next is the vestibular system. And I'm going to point out here, if you can see my cursor, it's this blue figure, and there's three kind of semicircular canals that they're called. And those canals feed into this vestibulocochlear nerve. Our vestibular system sends messages to our brain that tells our brain how our head's positioned in space. The best way to kind of describe it is, think of a leveler that you would use on some type of home improvement program. And that leveler has that fluid ball that moves as you move the leveler up and down. That's what's happening in your vestibular system, is we have fluid that moves within the canals that helps orient our brain to how our head's positioned. What can happen within the vestibular system is there's a lot of different diseases and disorders that we can get that impact that vestibular system, that lead to issues like dizziness and vertigo. This is an issue that gets treated by way more than just physical therapists. A lot of times ENT docs are involved, neurologists can be involved. So there's a big team treatment approach to normally the vestibular system because it's so complex. The somatosensory system. The somatosensory system, in the most simplest terms, is our body's awareness of its position in space. Okay, really what our somatosensory system does is it's concerned with perception of a ton of different senses like touch, pressure, temperature, position, movement, and vibration. And it sends a message from our periphery to our central nervous system, areas like the spinal cord, brainstem, and the thalamic center in our brain. Okay. To give an example of what it does, picture walking outside and you step on uneven ground and your ankle rolls out. The message gets sent from our ankle up to our spinal cord and says, hey, our ankle's rolling out. We need to act quickly or we're going to fall. Message gets sent back down to the ankle, to our muscles, and says, hey, muscles, our ankle's rolling out to the right. We need you to roll back in to correct the position before we fall. And it's a very, very fast response that is able to correct our position. What happens is our sensory system, the conduction velocity, or how quickly that happens, decreases over time. And that's just part of normal aging. So if that system isn't responding quick enough, it could lead to falls. And then there's conditions that are very common among our older population that even speed up that deterioration even faster. Conditions like diabetes and neuropathy can even speed up that decrease in sensation even faster. And the fourth system, and the system that myself as a physical therapist work with the most, is the musculoskeletal system. So we're talking muscles, bones, joints, and obviously this system plays a big role in our balance because we need the strength in that system to be able to support us when we're up and moving. And the best thing that we can do to give that body support is exercise. So are we, or are our clients, patients, are they exercising enough? The CDC recommends that we participate in at least 30 minutes of moderately intense strength training 2 times per week. I can promise you most of our older adults are not getting that. So this is definitely an area that we can work on and work with providers in the area to help get our older adults moving and help get them the exercise that they need to help prevent these falls. So here I have outlined an exercise program. These are all exercise guidelines that come recommended by the CDC. I know when you first read this, it seems like a lot, a lot of time every week dedicated to exercise, but this is what they this is what they recommend for older adults. 30 minutes of aerobic exercise 5 days per week. 2 days a week of strength training for 30 minutes. Same thing for stretching and balance. Okay, all of those 30 minutes, 2 times a week. And I can promise you a large majority of our older adults are not getting that level of exercise either. So we're going to talk about what does a solid falls preparedness, falls prevention program look like? What should we be doing? What can we do to combat falls? And a research study done by Hewitt et al. Says that at the very least, a robust exercise plan is recommended. They did a study, they took an exercise group who completed 30 minutes of strength training twice a week. And then they had a control group who did not exercise and did pre and post tests and found that the group who exercised significantly decreased their risk for falls compared to the control group who wasn't doing anything. So we know that exercise at the very least helps prevent falls. But a study done by Tricco et al. Took it a step further. And they took a control group who's doing a standard exercise program, and then took a research group who participated in all these things listed: a visual assessment, an environmental assessment. So they looked at their home to make sure their home was safe, didn't need any adaptive equipment or anything like that. They did a full medication review and also an in-depth exercise program that we showed on the last slide. And they found that that group compared to the exercise control group significantly decreased their risk for falls. We're going to talk about the STEADY program, which was launched by the CDC a few years ago. But these 4 items right here are the gold standard for fall prevention programs. So I'll say it again. It's an annual visual assessment, an environmental assessment, a full medication review, and an exercise program. Those 4 items are the gold standard that the CDC STEADY program recommends to help combat falls for older adults. So if you are someone working with older adults, you see older adults in your line of work, your practice, this is something that we need to be sure that they're doing. We need to be sure that these 4 things are in place if we're going to be doing our best to combat falls. So the CDC STEADY program, I just listed just put the website there. I highly recommend that everyone go and check it out. There's a ton of awesome resources for not only healthcare providers, but for patients and for caregivers as well. Tons of resources. And this can also easily be found just through CDC STEADY program. Google search, it'll take you right to the website. A lot of good information on there. And I did highlight just a couple of things that I like that are on there. One is a falls risk factors checklist. Now this can be done by healthcare providers, going through this checklist with your client, patient, and seeing where they fall on these things to give you an idea of how high a risk they are. And another resource that I like a lot is this self-reported questionnaire. So this is something that a client or patient would be filling out, and they go down through and just mark yes or no for each question. And any score of 4 or greater puts them at a higher risk for falls and indicates that they should be doing something more, whether it's a conversation with a doctor or what have you. But just read through this and notice it doesn't take a whole lot to get you to 4. If you've had a fall in the past year, that already puts you halfway there. That already gives you 2 points. And there's a lot of other things that can get you to 4 pretty quickly. So I think this is a very valuable tool for all older adults to go through to give them an idea of where they stand as far as fall risk goes. And with that, I will stop sharing my screen and I'll turn it over to Jenny.
Thanks, Mitch. Get this pulled up over here. All right. So I'm here to kind of talk about the other half of this topic, which is home safety and home modifications for the older adult. And I want to start out looking at why do we really need home modifications and how do we benefit from them? So implementing home modifications within our home can help to improve independence. It can increase function. It can help to decrease fall risk. It can help to improve quality of life, and it can even provide support to caregivers. One study I found, it showed the implementation of home modifications can reduce the need for caregiver assist in the home by up to 46%, which is pretty significant. And while I was gathering information for this seminar, I was trying to kind of think and look at studies that had overlap between OT and nursing. And I found this Capable program through John Hopkins, and it involves a trio of an OT, a nurse, and a handyman. And it aims to improve function through implementation of home modifications. And their study found that $3,000 worth of modifications put into a home can save up to $22,000 of medical costs. And they also found that implementation of home modifications can cut disability in half and help to reduce depressive symptoms. So first, I want to go over some factors to consider before we go into specific home modifications. I think there's a lot of shame and stigma in our society, just not only with aging, but within older adults of putting these modifications into the home can be seen as a loss of independence, make people feel dependent. So I think it's really important having really open dialogue and communication between all involved parties, making sure we're using person-centered language and trying to kind of change that outlook to increasing function versus loss of independence. It's also really important to think about the psychosocial factors involved, especially with COVID right now. We have higher rates of depression, higher rates of social isolation, and depression has been associated with an increase in loneliness, lower activity engagement. So older adults, if they're depressed, they're not moving, they're not using their muscles, which is making them weaker and puts them at that cycle that Mitch was talking about, that kind of vicious cycle, and puts them at a higher risk of falling. And then as far as environment goes, a 2018 AARP home survey showed that 3 out of every 4 adults would like to stay in their home and age in their home. There's more and more people wanting to stay in their home, especially with the pandemic, for infection control reasons and for high prices of some assisted living facilities. It's a lot of people want to stay in their homes longer, so they're looking for these types of modifications. And while there is a trend kind of towards this staying at home, there are also many older adults that don't really have that option to stay at home. They don't have the support systems or the money to. So the important thing is to really create a home environment no matter where you're implementing these home modifications. And it kind of goes to my last point of independence for people looks different depending on where they are and who they are. So I really want to kind of stress this just right challenge and this multifactorial approach to aging. There's hundreds and hundreds of home modifications out there that we can put into a home, but it won't necessarily benefit the individual. There's kind of like a delicate give and take between progressing someone as far as they can, kind of progressing their strength, their balance, their muscle mass, But then as we age, there's a point that we might not be able to get to that 100%. So this is where the home modifications kind of come in and can help to support independence. It's important to assess the level of functioning and need of the person for them to be successful. For example, I'm sure Mitch will agree with me. I like to use a lift chair as an example. A lot of people love lift chairs. They're really great. It's like a recliner that helps to lift a person up into a standing position. And if someone is weak, it's a really beneficial modification to a home. But if somebody is using it and they get kind of accustomed to using it over and over, they get to a normal level surface, your standard toilet, your dining room chair, and they can no longer stand up from standard heights. So this is kind of an example of something you want to promote independence, but you don't want to hinder performance. So I would like to introduce this model of practice that's used pretty widely in occupational therapy. I think our medical system right now it kind of has that medical focus of take this injury and how can we make it better? Look at this disease and treat the disease. And this PEOP model, which stands for person, environment, occupation, and performance, it considers how the environmental factors affect the way a client performs daily activities or engages in occupations. And it has these intrinsic and extrinsic factors that feed both into the occupation that's being performed and the person's level of performance. And it creates this kind of sweet spot in the center, which is occupational performance or independence. Home modifications can be diverse in both design and in purpose, and they involve a comprehensive assessment of the individual and their environment. And I'm going to kind of start going into some specific home modifications. So I divided them up into both intrinsic and extrinsic factors. So we're going to start with the intrinsic aspects. So these are some modifications that older adults can kind of implement within themselves versus modifying the environment. For task modification, this could mean if you have balance deficits that it's not safe to stand, sitting at the edge of the bed to put your pants on. So you're kind of taking that balance component away, you can focus on putting your pants on safely. If you have somebody in the bathroom, like Mitch was saying, falling in the shower, it's very slippery. Getting a terry cloth robe and just putting that on and that drying your body instead of reaching and leaning and kind of challenging that balance component. If you have trouble going down the stairs or there's a higher risk of safety, putting your laundry in a backpack and putting it on your backpack, and then you have both hands free to use the handrails to get down the stairs. As far as energy conservation work simplification goes, that just includes kind of simple modifications throughout your daily routine, such as taking rest breaks before you need them, before you get fatigued, spacing out chores throughout the week so that you don't overwhelm yourself, really knowing your limits so that you don't overexert yourself, and then planning ahead for any harder tasks that you have to do. Ergonomics and body mechanics include just general body safety. When you're bending over, making sure you're bending with your knees, not with your back. If you're carrying something very heavy, keeping it close to your body, not keeping it out in front of you, not over twisting when you're moving, those types of things. And then lastly, breathing techniques. So this is really important for our older adults with cardiopulmonary issues, or even somebody as they're kind of working back up from rehab or things like that. If you think of, if you're standing at the sink or in the kitchen and you're cutting vegetables and you're starting to kind of get fatigued and short of breath, if you're not implementing these types of strategies, you're kind of focusing in on, oh, I'm kind of losing my balance, or I'm so short of breath. And then it's taking your focus away from cutting the veggies. And then that is when mistakes can start to happen. So it's really important to implement these modifications before the mistakes happen. I just want to touch on a couple sensory modifications. I know Mitch talked a lot about vision, and vision is very important when we are implementing home modifications. And kind of these two parts I want to touch on quickly is lighting. There are multiple different types of lighting that you can implement within an environment. There's task lighting, there's ambient lighting. And a lot of people think just make it as bright as possible and that will help. But that can actually be harmful. It creates a glare. So it can be harder to see things, harder to see objects on the floor or where things are going. So that's something really important to think about. And then contrast as well, making sure there's, whether it's texture or colors are different. Somebody with macular degeneration or diabetic retinopathy, if they're going down their stairs and it's all the same color, it's not going to pop out where that lip of the stair is. So putting tape, whether it's neon tape or if it's brown stairs, the neon color tape kind of thing, that's really important. And then you want to think about cognition as well. So a lot of these modifications, if you have somebody who is cognitively intact or has mild cognitive deficits versus somebody who has a little bit more moderate to severe deficits, you're going to change your modifications based on that knowledge. So you want to make sure that like if somebody has intact cognition, they can implement these strategies that we've just talked about. But if you have somebody with a little bit more severe cognitive deficits, new learning won't occur. So you have to kind of modify, and whether it's using signs or you have to rely a little bit more on the external modifications. And with that, I'm going to kind of move to these extrinsic modifications. So the environmental home modifications, I'm going to go over some architectural, some assistive devices and adaptive equipment, bathroom equipment, mobility devices, and transfer aids. So architectural modifications, these can be semi-permanent or permanent modifications, including grab bars, whether it's in the shower, going in and out of your garage, next to your toilet, or in your hallway. Those can help to reduce fall risk. Modifying a tub shower to a walk-in shower to reduce that risk of falling while stepping over into the tub. Adding non-skid liner to surfaces like the stairs or inside the tub or shower. Making sure toilets are ADA height. Addition of ramps, and even addition of stair glides. That's a good example, like a task modification, somebody moving their bedroom down to the first floor. If that's not an option, implementing a stair glide so that they can still stay at home and safely get up and down the stairs. And then, so these are some devices that someone can use to increase their safety during their daily routine. So using a reacher, a sock aid, a shoehorn, a dressing stick while you're getting dressed in the morning. Using a long-handled sponge to scrub between your toes, scrub your back while you're in the shower, reducing that kind of extraneous movement while we're in a wet situation and on hard tile. And then a toilet buddy and a bidet. These are really key assistive devices for older adults. A lot of arthritic changes, it can be hard to reach to wipe. And these devices can be the difference between someone having to stay longer in rehab or being able to go home and be independent in their toileting. So this is some bathroom equipment. A lot of these 6 items look very similar, but they have all have different functions and they can benefit somebody in a different way. And it's really important kind of to go back to assessing the person, what they need, so that you can give them the right modification needed. On the top right is a commode, and that helps to, it can be put beside somebody's bed so that they can still use the toilet instead of soiling themselves in the bed. And then the bottom left one is a tub bench, which can be placed into a tub. So if somebody is unable to get into their tub shower, this allows them to sit on the outside, they can swing their legs in, and then they can shower in their shower. I think for the sake of time, I'm not really going to go through these mobility devices, but there's many different types of mobility devices that somebody can use. And I think it's really important to consult a PT or OT to determine the right device needed. You don't want to just throw somebody in a wheelchair because you're afraid of them falling, and we don't want to hurt them, because that can then hinder performance and that can prevent them from being independent. So really, again, that just right challenge, making sure we can find that sweet spot for our older adults. And the last modification I want to talk about are some transfer aids. This one here is what Mitch was talking about. That would be a good device for adults to kind of help stand up after a fall. But some of these transfer aids can range from a small handle that you can put in your car to help stand up, all the way to a slide board that can allow somebody that can't stand to slide from surface to surface, from a wheelchair to the toilet or from a wheelchair to their bed, to be functional. So in summary, home modifications and adaptations can reduce fall risk and increase safety, but they aren't the singular option. It's important to consider a multifactorial approach as you're looking at home modifications, and really look at the intrinsic and extrinsic factors of a person, their environment, their performance, and the specific occupation they're performing in order to holistically address home safety and fall risk. And these are just a couple resources. AARP Home Fit Guide is, it's a room by room checklist of different modifications you can implement in your home. And then the AOTA reference, the fall prevention tip sheet, and the focus on fall prevention and home modification booklet is 10 to 15 evidence-based articles on fall prevention and techniques for home modifications. And that's it.
Well, thank you so much, Mitch and Jenny, for an amazing presentation. We're going to come back hopefully for some questions and comments in a moment, but I want to pause for a little bit to allow everyone an opportunity to do the evaluation. So Jenny has put the link into the chat. If you're a registered nurse seeking contact hours for this seminar, please be sure to complete the evaluation, but we actually encourage everyone to do it so that we can get feedback not only on the seminar, but for future planning. So I'm going to pause for a couple minutes to let people complete the survey, and then we will be back with some Q&A and discussion. Okay, there may be some that are still finishing the evaluation tool, and that's fine. Please complete that. You can do it after the seminar, and again, it will be emailed to all participants within 24 hours, so you can do it at that time as well. And it does need to be completed within a week of the seminar. So, so thank you, Mitch and Jenny, for pausing there for a moment. There is a comment in the chat that I want to start with. Sarah Songer mentioned that she has both family and client visual issues when they've had bifocals instead of progressive lenses. In fact, her ophthalmologist wouldn't prescribe them for her. He said, you don't even walk through a door without hitting one side of the other. If I prescribe bifocals, you'd fall the first time you tried going down the stairs. So I guess if you want to comment on the type of lenses, if you see any increased risk of falling as a result of that.
Do you have any input on that one, Jenny?
I would say I haven't had particular clinical experience with that, but it I guess as a clinician, it makes sense. If you're going down the stairs, you're looking down, and that's the reading aspect of your glasses, which would then distort the vision that you're seeing. So it's almost like you kind of need two glasses, one for kind of ambulation and getting around, and then others for reading.
Yeah, I've used kind of, you had mentioned it, Jenny, putting tape down on stairs. Just to kind of help with knowing exactly where you're going, especially with bifocals. I've heard a lot of people mention stairs are a challenge when there is that depth issue. But sometimes it was like marking the steps can help with that.
Yeah. And I think whatever the lenses are, whether they're bifocals or progressives, just having that awareness that you may be looking out of a different part of your glasses when you're doing different activities, and just being that much more mindful about it. Marie is commenting that this was such an excellent presentation, and thank you both. She agrees that stigma is such a significant factor, and that it does lead to underreporting of falls and avoidance of addressing the risk of falls. Do you want to comment on that at all?
I'll just mention, I mean, absolutely. Yeah. And it's a big issue. And I think a lot of it was twofold. And I think someone else had mentioned something in the chat. One is the caregiver aspect, whether it's the spouse or kids of older adults. And then sometimes it's a healthcare provider too. Someone suffered a fall, and our next answer is to pretty much put them in a straitjacket and lock a wheelchair and call it a day. So it leaves older adults afraid to mention these things and not getting the care that they need. It's a major issue for sure.
Yeah. And that oh, go ahead, Jenny.
No, you go ahead.
I was just going to say that kind of reminds me of a thought that I had at the beginning of your presentation, Mitch, when you said it's important to realize that we cannot prevent all falls. And I think that that's, as a former director of nursing, I would sometimes have family members come into my office and really threaten myself and our organization about, if you let my father, fall again, this is what's going to happen. Or we would even have family members that would say, I don't care if you need to tie my loved one to a chair. I do not want them to fall again. So it's really that kind of shift in our thinking about all of these strategies that both of you presented it to us today so well, in terms of, yes, we want to reduce the risk of falls and certainly serious injury, but also that concept of fall preparedness and all of that encompasses. And I think both of you did such a wonderful job explaining, many of the factors that impact the risk of falls, but also more importantly, what we can do to be proactive about, maximizing someone's strength and abilities. And it was even interesting, Mitch, when you were talking about helping people kind of prepare for the fall in terms of the hurting aspect. It made me remember of when my sons learned to snowboard. The first lesson they had on the hill was how to fall. So this approach, are you seeing this more often with practitioners, that they're using this type of approach as opposed to focusing on preventing the fall itself?
For me personally, I don't see it a lot. I think it's still kind of a newer concept, and it definitely takes some confidence from the provider aspect to be willing to get someone on the floor and have them go through that process. And I think it's still a relatively new thing that not a lot of people have tried, but it's something that's been well researched and something that makes a big difference in the clients for sure.
Yeah, and I think your explanation of all the different physiological systems that are playing into our ability to stay upright is really important, because I think we look at it kind of unilaterally. And Jenny, you were talking about the lift chair. That there's such a great benefit to using the lift chair, but at the same time, it could impact their ability to sit on the toilet, for example. I thought that was a great example of something that we see as a benefit, but there could be other ways that we need to look at the home. Do you want to comment a little further on that piece?
Yeah, I think it's different, obviously, kind of per person, you assessing their specific needs, because yes, that for people who don't have that muscle strength right now to really stand up, that's a really vital component. But I think I've had so many conversations with patients of, oh, my family saw this and they got it for me, and they don't particularly need it. And even like facilities I've been in, they offer them, like the rooms have them, and I'll walk in and I'll see a patient and say, like, let's go to the bathroom, and they'll crank the lift chair all the way up. So I think really like trying to these kind of learned behaviors that end up being a little bit detrimental, trying to reframe them in a different way.
Right. And even if you think of the timed up and go test, that simple test of mobility, and getting up is part of that test, getting up off the chair. And so if they're accustomed to that lift chair, that will have an impact. We probably have time for one more question. And Diane is asking about pets in the home as a potential hazard. Any comments and recommendations around that?
I would say, I mean, I didn't have time to say it, but I actually had pets on my list as a extrinsic risk factor for falling. Especially dogs and cats, they run between your feet. They like hang around the walker. So I've instructed patients on trying to kind of almost train the pet away, and kind of, do some training on the side so that they know to not kind of walk in front of your walker and things like that.
And as Mitch was talking about lighting at night and getting up to go to the bathroom, I was thinking, yeah, and then that's when the cat slips in front of you. So I can see that being a potential problem. Well, it is 1, so we need to end, but thank you so much for this fabulous presentation. On behalf of myself and the CGNE leadership team, we really appreciate your time and effort in sharing all this wonderful information with us. Gave us lots of things to think about in terms of working with older adults. So thank you so much for your time. Really appreciate it.